looks like people have stopped trickling in for the moment. So I think we can go ahead and get started. If you didn't catch it as you got in, if you could introduce yourself in the chat with your name, where you're based, and your profession, that will help us all get familiar with each other before the roundtable discussion. And hello again. Thank you for joining Roundtable 1B, Leveraging Technology for Comprehensive Cleft Care Team Building and Patient Care. A couple of housekeeping notes before we begin. If your bandwidth allows, please keep your video on so that we can see one another during the presentations. Please stay muted during the panelist presentations to reduce background noise, but do feel free to use the Zoom reaction button to encourage your colleagues or respond to ideas. Please do post questions and comments in the chat to inform the roundtable discussion afterwards. And again, for those of you who are just joining, if you would go ahead and introduce yourselves in the chat with your name, where you're based, and your profession, that would be great. So as you all know, this will be structured as a panel presentation, followed by an open roundtable discussion. And I will introduce our moderator, Debbie Sell. Debbie is a Cleft specialist speech and language therapist and senior research fellow in ORCID at Great Ormond Street Hospital in London. So I will turn it over to her to give a little background around the session and to introduce our first panelist.
Thank you very much, Sarah, and for your introductory comments. And I'm delighted to welcome you all from all over the world to our roundtable. There are about 40 of us that have signed up, and we have representatives from 20 countries with 11 different disciplines, and that's from 5 out of 7 continents. So we've done very well. And one of those was the Antarctica, so I don't think that one particularly counts. So the aim of our presentation, of our roundtable then, is to look at this issue of technology. And we just heard how there is a digital divide. We need to look at it in terms of how we're delivering care and how we can stay connected with our colleagues. We just heard how important that is as a Cleft team, and also to support each other. And also to ensure that we continue with our education and that we access supervision and mentoring. What we want to do is to sort of listen to try and think about the difficulties and come up with some solutions that you've found from working at grassroots level, and to share and learn from those experiences. So I'm really looking forward to this, and our first speaker is going to be Usama, Dr. Hamdan, Usama Hamdan, who's a otolaryngologist, facial plastic surgeon based in the States. Many of you will know him, but significantly for this particular panel, he is the founder and president of Global SMAR Foundation. So over to you, Usama.
Thank you so much, Debbie, and thank you, Hugh. I think, Sarah, you need to start it from the beginning.
Hi, my name is Usama Hamdan. I'm from Global SMAR Foundation, and I'd like to talk about innovative initiatives to optimize cleft care during this challenging time by leveraging technology. Global SMAR Foundation is a nonprofit organization dedicated for the delivery of interdisciplinary cleft care throughout the world, whereby we empower our local partners on the ground and help in the development of cleft care centers for longitudinal care, utilizing our 3+ decade experience in development and carrying out of outreach cleft missions, not only surgical, but also dental, orthodontic, psychosocial, and speech. Our sustainability initiatives include comprehensive cleft care workshops with in situ simulation, task training, fellowship training programs, and augmented reality. Our teams have increased in size. We're average around 50 to 55 people from the United States and internationally, and with our partners on the ground as well. The healthcare systems worldwide has been quite challenged during the COVID-19 pandemic, and the surgical outreach programs targeting low and middle income countries have been especially affected due to team safety, patient safety, travel restrictions, quarantine demands, and the shortage of personal protective equipment. Technological evaluations and innovations have enhanced our ability to connect with our on-site teams and follow up with our patients and their families on a regular and timely basis. The remote and post-operative care and wound management has become available utilizing telehealth. Educational videos such as speech therapy sessions with guided exercises, counseling our patients and their families with feeding and nutritional assessment, guiding parents and their families on pre-surgical orthopedics and taping, videos centering on healthcare-related topics such as proper hygiene and COVID-19 precautions, and psychosocial support through community-based initiatives. An example of the telehealth utilization in pre-op screening. And feeding support. And pre-op taping. As well, it allowed us to do post-op follow-up care. And with our team members from Ecuador and Boston, and talking to the patients and their families. It also allowed us to do pre-surgical taping guidance and follow-up with our patients. The development of electronic medical record was done in-house in 2018. It's easily accessible for all our team members worldwide. It's a centralized record keeping for patients' charts and follow-up notes, and plays a pivotal role in enabling provisions of multidisciplinary continuity of care despite the obstacles brought by the COVID-19 pandemic. It promotes trust, respect, and confidence between patients and healthcare providers, as well as on-site healthcare professionals and visiting teams. Augmented reality is something else as well that Global Smile Foundation has developed from 2014. This is during the initial phase of the development in 2014. Dr. Vallas is in New York, I'm in Ecuador, and his hands are in the surgical fields with me. And it really allows us to remotely guide the surgery with our local partners. It allowed the remote virtual drawing on a 3D environment in real time. The US-based Global Smile Foundation surgeons can remotely assist and guide our on-site colleagues during live surgery. It provides virtual support year-long, and our on-site partners strengthen and reinforce their skills. This is an example basically of our surgeons on the ground in Ecuador being guided through the virtual augmented reality. And this is the taping on a lip model. And this is during the live surgery. And our international comprehensive cleft care workshops have allowed us to share our expertise with as many people as possible, whereby our attendees have the ability to work on individualized model with some of the world leaders in the field. This is our last meeting in Lima, Peru last year, where we doubled the numbers from the previous year. Our Chennai, India workshop this year was converted into a virtual one that will be carried over 2 weekends starting next month, October 2nd. And there has certainly been a lot of challenges for us and for our patients and our team providers on the ground, including access to internet, slow internet connectivity, low quality of photographic documentation by the parents of our patients, and other challenges facing our team, including that we had to cancel 4 missions so far in 2020, and access to our facilities in on-site has been limited because some of them were converted to COVID-19 units, and the affordability and availability of transportation for our patients. We're quite concerned about not being able to resume our daily and annual missions short of the development of a safe vaccine. However, this downtime has allowed us to concentrate on publishing a lot of articles in peer-reviewed journals. I would like to thank all of you for this opportunity to share the experience of Global Smile Foundation, and I look forward to our interactive session with our colleagues. I just wanted to leave you with a saying from our president of the foundation in Ecuador, Denise Franco: it's not what fills your pockets, it's what fills your hearts. We really all need to strive in doing the best that we can in outreach setting and to make a difference in the life of patients.
Okay, thank you very much, Usama, and I look forward to the plenary, to some of your responses. So our next speaker, I'm very delighted to welcome Dr. Adeola Ulisanya from the University of Ibadan in Nigeria. She's a member of a Cleft team and has interests in Cleft, speech therapy, and pre-surgical infants orthopedics, and she's a senior lecturer and oromaxillofacial surgeon by background. So over to you, Adeola, and thank you for your presentation.
Yes, thank you, Debbie. I'm happy to be here. So I think, Sarah, you can play now. From the beginning, try to start from the beginning, please.
Everyone, I'm Adeola Ulisanya. First, I wish to thank SmileTrain and COCP for giving me the opportunity to share our experience from Nigeria. I'm a consultant oral and maxillofacial surgeon with special interest in cleft care, and I work in the University College Hospital, Ibadan, Nigeria. Our cleft program consists of several specialties, including plastic surgery, orthodontics, pediatric dentistry. During the pre-COVID era, our clinics are physical. We see our patients on a clinic basis. And the significant proportion of our patients are from the low socioeconomic status. Therefore, communication devices such as the smartphones or internet access or data support are items of luxury. During the COVID period, which was acutely between the April 2020 to July 2020, everywhere was shut down. The markets were shut down and the public gatherings were prohibited. Our care was limited to phone calls and to provide psychological support for our patients. Presently, the restrictions are being eased off and public gatherings are allowed with caution. And we're hoping that even the schools will resume fully by the 24th of this month. That's a few days from now. However, the COVID pandemic has modified the way we deliver our care. The clinic sessions have resumed since the lifting of the lockdown, and at least 2 specialists are present at each clinic sessions. The others who are not there are updated using pictures and videos from a dedicated laptop. We also share links of webinars in order to improve ourselves and our care. The aspect whereby our modifications has impacted the most in cleft care is the component of communication. And this way we provide dedicated phone lines to our patients, and we also collect their own phone numbers on a dedicated phone. And the complaints can be sent to the Cleft team via this mode. We also encourage patients who do not have smart devices to meet a neighbor or a local vendor who has this facilities to send pictures, including the patient's information. Speech therapy, tasks can be sent via this mode using the images or videos, and then they can also be returned to us using this mode. For the NAM plates, we now modify at the very first visit we complete the modification so that the number of visits for the patients can be reduced from about 8 visits to 2 visits. Another aspect of the nasoalveolar molding therapy is the modification of the nasal stent from being wholly acrylic to a hybrid form that has metallic components. The hybrid form is not as easily, it doesn't break, so the patient doesn't have to come back to clinic to get a new one every time this happens. Another aspect that's modified is our surgical care. We play videos to prevent our patients from crying during the short period of staying in the operating suite and then endotracheal intubation. Another aspect whereby we have used leverage of technology is the aspect of intubation. We can use a smartphone connected to what's called a boroscope or an endoscope. And this boroscope is relatively cheap and therefore readily available to us. As an endotracheal tube being inserted using the phone. Another speech therapy component that has also been modified is the use of modified locally fabricated oral nasal listener using 3 stethoscopes. This way we can get to listen to nasal emission without moving too close to the patient. Now, the resources we have been able to come up with are basically low-tech with minimal risk. And the endoscope shown described can be easily disinfected in a similar manner as per the conventional endoscopes. The takeaway points that I want to highlight here is that distance is not a strong limitation to provision of care anymore. And patients do not have to wait for a scheduled clinic visit in order to make their complaints known to the Cleft team. Low socioeconomic status is also not a very strong factor or limitation to Cleft care anymore. At this junction, I want to thank SmileTrain and COCP for providing this opportunity for me to share our experience from Nigeria. Thank you.
Thank you very much, Adiola, for a very interesting talk. And we'll now move on to Carolina Gutierrez, who is a speech therapist in Costa Rica. And she provides therapy to children and help to therapists in the schools as well. So over to you, Carolina, for your talk. Thank you.
Thank you, Debbie. Hi, my name is Carolina Rivera Gutierrez. I'm an SLP from San Jose, Costa Rica, and I work at the Asociación Costarricense Pro Niño Labio y O Paladar. We are a small but powerful team of 5 women. We provide psychological and language care for children and their families affected by cleft and burden ward. The association receives 500 patients a year. Our pandemic focus is to continue in empowering families while we continue to work from home. Challenges. COVID-19 has had a large impact on Costa Rica. A growing number of cases has paralyzed the country and left population isolated in the constant state of uncertainty. For that, our strength goes to collaboration and total support for all 5 team members. We have a great communication system, not also with the members of the team, but with the parents. And also holistic approach for treatment. That means psychological and speech work hand in hand. In the opportunities, family already use available free mobile technology, like Zoom or WhatsApp. And for the weaknesses, we have that some regions in the country with low connectivity. For COVID resolution, what platforms? Well, for virtual speech therapy and psychosocial counseling group therapy, we choose Zoom because it's an easy way to interact with parents and the kids. And the risk that we identified is that parents sometimes loses the interest. That's why we have to think and create more interactive sessions to maintain children participation during virtual sessions. And resources require, well, time is the most important resources because virtual sessions require more planning, agility, creativity to keep the dynamic without losing child's interest. For my first COVID response, it will be virtual speech therapy. And the key factors are, the most important are the parents, because if we need to work with children less than 3 years, parents will be our main tool. Then we have to think of an interactive, attractive, and dynamic session designed for every kid. How do we accomplish this? Well, with a great communication with the parents, using the child's environment supported with technology and games. And we measure the performance because the parents are constantly evaluating child process after each virtual sessions and sending us audios or videos or even sending private messages. And constantly and perseverance for the parents with virtual care and home practice. For the second COVID response, it will be virtual group therapy workshops. And workshops not only for the kids, but also for the parents. The key factors here are that interactivity, encourage interaction, dynamic group sessions, parent support, and education. What did we do for accomplish that? Well, with different information that we know the parents will be attracted to, and also the kids, using also games and dynamics, but well, giving more importance to the technology part. And how did we measure the performance? Well, with family feedback, the parents send us messages or audios or even videos. Also, the parents tell us that they love, the kids love the sessions, the group sessions, because it's more interactive. There are 5 kids at the same time with different house activities or experience. And the kids, when they are during the workshop, they do not think of pandemic because the activities are fun. So that's the most important thing here. And also the level of commitment and participation for the parents during the workshop. Key takeaways for the participants. Well, offering options to reinvent the way we approach and interact with patients and their families. Virtuality provides tools to enhance the need presented by each patient using their environment. Technology shortens distances. Why don't we consider holding international workshops with kids? In this way, we can interact with others and learn about their cultures. Virtual sessions with other speech around the world will implement different techniques and tools for the sessions. Thank you for your attention.
Thank you very much, Carolina, for a really interesting talk as well. We're now going to be opening up the discussion. So just to remind you, in this part, you can put your video on so that we can see each other and hopefully then be able to get to know each other, and ideally mute yourself if others are talking, if we get too much sound interference. So you can either put your questions into the chat, or if you wish, you can raise your hand. Let's just see how that works as well. So I'm just going to get to a view of everybody and myself. Let's just see, and hopefully we will start to see people appearing. Fantastic. Excellent. So I don't know if anybody wants to kick off this discussion. Usama and Puneet, you had some discussion about NAM there that you have talked about in terms of technology. Can you just speak to that for those of us that are less familiar with NAM?
Yeah. Hi, Debbie. Thank you for giving the opportunity. Actually, recently we scanned the impressions of cleft babies, and we are making aligners. So aligners don't require the patient to come every week, and we give the whole set of aligners together to the patient so that, you know, it can be, we can just online see the patient's progression, and simultaneously everything is happening. So it just requires you to call the patient twice, and its very cost benefit ratio is very good. So we published it in the Cleft Palate Journal, and we're publishing second part of it, comparing it with the conventional Grayson and the other appliances.
Okay, so this is basically telling us about a method that is possible to do through seeing patients less frequently.
With technology. Because here you don't need to do adjustments on the appliance of the patient. The appliance is already adjusted and delivered on day one.
I understand. Thank you. Thank you. So that's one very interesting, actually something that we've learned, because we've heard quite a bit about speech therapy virtually, but less about orthodontic care. So that's really good to hear that. Yes, Adiola, please do.
That on the same topic of the NAM, where in places where we don't have like the aligners, we are also using the Grayson's method, but that's with the acrylic plate. I think Prof also mentioned it in one of his previous presentations, that we can actually modify at the very first visit, modify the plate. NAM means nasoalveolar molding. That's to, in order to have a better alignment of the alveolus and the nose and the lips. So we can actually do the modification at the very first visit. So the number of visits of the patient can be reduced to about 2 or 3 from about the conventional 8. And we've had some successes with that. I think
Usama, you want to say something?
Professor Batra, I think was.
Okay, come back, Puneet, by all means.
Yeah, actually, we did a study a few years back comparing just doing all the modifications in one go versus making a Grayson appliance and calling the patient every week. And we found that both the alveolar molding in both situations was similar. So, if you were working in a setup where the patient cannot travel, the good idea is to do all the modifications in one go. So that's what Dr. Adiola was also discussing, that, if you do that, this is the time to do it. Because we have scientific evidence to say that alveolar molding will not change if you do it in one go or you call the patient multiple times. So then, technology would take over.
Thank you very much, Puneet. Can we move the subject on? I'd like to pick up on something to do with actually ethics around the augmented reality. There's a question for you on the chat, Usama, about ethics committee approval and how that is difficult in Brazil. That's from Fernando Henrique.
We have not had any issues with this situation in all the countries that you have worked in, be it in Peru, El Salvador, and in Lebanon. And we've just published a paper actually in PRS. I've shared with everybody. This paper came out actually last week, and certainly didn't require even the ARB approval in that regard.
Okay, that's interesting to know. I'm sure that different ethics and different committees in different countries obviously often do have different views, and it can be a very challenging sort of block or barrier. Let's move to speech therapy. Carolina, there was an interesting question from Midori regarding how you're dealing with the little ones with no computer, the ones with the mobile phones only. She's been doing some PowerPoint activities, but how is that on a mobile screen? Thank you, Midori, for your question.
Yeah, normally most of my patients, they do not have computers, so we use their phones. Well, it works actually good. Sometimes we send them the PowerPoint presentations, but most of the time we use their toys during the sessions to make it more interactive, or we make activities so they can follow instructions and make it more dynamic during the session, so it works very well. Also, one of the things that I use the most is the storytelling after the sessions. So we work, then we have like a playtime, and then we have the storytelling, but using the sounds that normally they have affected. So they love that part. Even the parents ask for me to send the videos after telling again the story, so the kids can like listen it at home. So it makes it more easy, an easy way to work with them.
Okay, so these children then are little ones who, is it more language work you're doing or specific work on articulation? Because it can be very difficult to have all the right materials without some control of that yourself, I think.
Such a, well, it's the time for innovation. So I have material for everyone. It starts from language stimulation, even to articulation for each sound. So I think that every material is custom made for the patient. I take the time for making it, and sometimes we switch it. We also work, well, I work with different ages since they're babies. And so I work with the parents, and also my oldest patients are 15, and it's more articulation problems. So it's more related to what a patient needs. So it's very custom made sessions.
Okay, thank you. So a question from Daniel Saremba.
You just muted yourself, Debbie.
Wasn't that clever? Right. How is the oral examination done in the COVID-19 era by the speech therapists? Does anybody want to add comments to that question?
It's kind of complicated. Most of the time I ask the parents to send me videos, or most it's like questions. So it's kind of complicated that way.
I was going to mention that you know, somebody mentioned about parents not having the phones or smartphone to use, because I use WhatsApp a lot because I'm in San Diego, but I go to, I do work in Mexico and just started in Venezuela. And so, you know, the WhatsApp, which is a lot of positives, but there are the negatives. And then with Venezuela, what I'm lucky is that they can, like bi-weekly, I'm starting to meet them. They have 1 or 2 patients go to the site because now they've got some limited ability to travel. It's limited because of course they can't travel every week. Like they have the weeks on and weeks off that the actual public transportation is even open for them to travel to get to the clinic. So I'm doing that. But I think, like Carolina mentioned, we just have to be, you know, just figure out outside the box. What can we do? I know that in certain cases with one of my organizations, they send materials, but of course I'm not gonna be able to send materials to Mexico or to Venezuela. You know, it's not gonna happen. So, but that within the United States, I've been able to do that, send materials, prep them. So this is what you're going to use, type of thing. That's what I do through I work in the school system. So that's what we do.
Okay, thank you very much, Glendora, for your comment. And one about, let's talk about connectivity. What about experiences of when you have poor connectivity or you lose connectivity during a surgery? Can we ask about that to the group?
Yeah, there was actually 2 questions. One about the connectivity, which at least in our experience with the augmented reality, even a 4G bandwidth is usually good. What we do is we work with the hospital and the internet provider to ensure that there's a constant, non-interrupted flow of bandwidth coming in. But even via the cell phone, this has also been usable. Without much of an issue. Certainly the WhatsApp has helped us with the post-op and pre-op evaluation. But in response to Matt about the questions about augmented reality and more complicated surgeries like cleft palate, if you probably recall from my talk, people don't jump into augmented reality overnight. People need to do training with us, need to work with us on missions and on site, and need to attend the workshops, and then we typically have them be assisted via the augmented reality. And so far we have used augmented reality only on lip and lip revision. We have not expanded that into the cleft palate specifically as well because of the more complicated situation. But again, the people who are working with us are people who've been with us for a long period of time and know our procedures and processes.
Okay, so I mean, interesting point that here you're saying you need training of professionals in certain contexts, and actually the issue of parent training was also raised by Rupa in her talk. I think she left on that note. And so is there any comments around parent training that we can open up at this point? and how your experiences of the need for parent training and how you do it. Have you got materials? Are they shareable materials?
And in our case, basically, our pre and post-op teams basically spend a lot of time counseling the patients and their families on what needs to be done. And then they actually follow up with them. We provide them both printed material and videotapes. And we have just developed actually an app on the phone that will allow us even to interact better with these patients. This is still in the development. And hopefully once this is out and released, I'll be happy to share it with everybody as well.
And is that for nursing care? Is it around surgery particularly, Usama?
Surgery, post-op care, as well as speech.
And for speech, that would be interesting for the speech therapists, I think, to look at that. That would be great.
Yeah.
Anybody else want to talk about parent training at this point before we carry on with some of the questions that are coming in?
Dushyant here. Can you hear me?
Ah, Dushyant. Yes, and I can see you. Fantastic. Continue, please.
Yeah. All right. So, question to Usama. Usama, since you have a wonderful module that you created for surgery, is there something that you have for NAM where you can actually have a simulation training program wherein surgeons learn the NAM technique, and then we can use Puneet's model to actually prepare the aligners and something like that? Do you have some kind of NAM simulation technique?
Basically, our NAM simulation is mostly done through our workshops that we're currently doing in Ecuador, and people are flying in to attend the very intensive condensed 1-week course with live on training. And so far we have not done anything online in that regard, but it's also in the works. And our board member and the lead of our dental division, Serena Kassam, actually, who heads our NAM division, is also on this call. So Serena, you can also comment, please.
Yes, we are looking at different modes of technology to advance, especially as the technology on NAM and the liners and intraoral scanning is moving forward. So I'd like to talk to one of the attendees offline who had just published an article as well, because it's a collaborative process.
Thank you. It's a fascinating discussion because we've got some really sophisticated ends of digital technology happening, particularly with Usama's foundation, and it's fantastic to see that. But we also have the other end of the spectrum, and Hughes asked, what's the role of CCC outreach workers in providing access to cell phones, Wi-Fi, to parents in rural vulnerable situations? Would anybody like to enter this discussion and bring any of their experiences as to the role?
Can I speak, Debbie?
Yes, Rupa, please do.
I think especially in community outreach, our real challenge is the technology at the end of where the child is, and it's not just about technology; it's about availability of the device, because what we've found is the whole family is sharing a device. And today, during this COVID pandemic, online teaching is going on. Parents are working from home, and to be able to pull this device out for anything that we want to do with the child, finding the time is not at all easy. So there is a challenge, and I wish we could think of some ways we could give support to parents and families specifically for the kind of work we're doing. Maybe some device that they could use on loan, for example, for 6 weeks or 10 weeks while we are doing, going through this process of therapy or connect or something like that, so that, we could get it back maybe and then share it with other families. But we really need to augment the technology at the end of the child, especially if they are not near the hospital. We have to look at it. Parents will not be able to afford it. I'm pretty sure about that. So if we could find ways where we could loan equipment and get it back, then that may be a thing, because many of our, especially for speech therapy, We may work in blocks of 9 weeks or 12 weeks or something like that, you know, and we could reuse this and get better equipment to the kids. I think that would make a difference.
Yep. So
yeah. Can I say something?
Yes, by all means. Who's speaking? So sorry, Adiola?
Yes. As regards to the Wi-Fi not being available locally, there's something else we do in our center, and that is we engage local vendors who can, at a small fee, allow you to make a call. And what we do with our patients who are far away is that they go to the local vendors, and via WhatsApp, they make a video and send. And then depending on the length of the video, there's a way that we can compensate them if we really have to use that feature. So that way we don't really get to buy them a phone, but at the same time, we can send WhatsApp images or videos through and through via these local vendors with a small fee.
And maybe there's something around the charities that are not spending money on traveling, actually, to support some of these local needs, particularly those at technology locally. Let's go further.
Speak a bit. Can I say something, Benjamin?
Yes, please go ahead.
Yeah, some charities actually do spend some money, but you know, because of the state of the roads, for instance, in my own environment, the insecurity that makes the local to take shelters in areas that are almost inaccessible, it's very difficult to get them. And then talking about the connectivity is a little bit dicey, because in the remote areas where they may stay 3-4 days without network connectivities. And you may only get them maybe once in 2 weeks and so on and so forth. Like I said earlier, it limits what you can actually do for the patients. I think the NGOs are, the one I work with, Smile Trains, they do compensate somehow for transportations and for feeding. But again, it doesn't really meet up with what are the needs of the patients.
Yes.
Thank you.
Thank you for your comment, and it's very salutary to appreciate those very sort of extreme difficulties. Let's move on. There was I just wondered if we wanted to take a question which Matt Fell put in the pre-conference chat, which is around education. And I think what you were asking was the extent to which we have different needs or locally now to do with education and training, and how much what is available out there, which is loads of stuff that are free webinars, how much they do answer and address the needs on the ground. Can we open up that question? Has anybody got thoughts on it? Does that suggest that actually the training that's provided, be it either aimed at low middle income countries or not, is appropriate and people are happy with it?
Again, I will talk about the Global Smile Foundation experience.
Thank you.
And we have just published another paper as well in CPCJ. I'll be more than happy to share it with everyone right now about our model for developing sustainable, comprehensive cleft care in low and middle income countries. And that involves the diagonal model of, having missions on the ground, training people, developing cleft centers, which is really the long-term answer for, the huge need. Developing our comprehensive cleft care fellowship program, training people, and more recently as well, our cleft workshop. And we show basically where if you train one individual over a 20-year period on an average of 200 patients a year, you're impacting 4,000 patients in the lifetime of that practitioner. So if you have 300 people signing up for a workshop, that's why, like what we expect actually next month, you're impacting the life of 1.2 million patients during that period of time. So this is really on the long term, after having been doing this for the last 33 years. You need to maintain quality. Each patient deserves and needs to get the best treatment possible, and not the botched up surgery of doing 10 or 12 cases in one room, or two cases being run in one room, and then ending up damaging these patients' lives and the lives of their families as well. The only way we can improve this is by raising the bar, as we have done with the World Cleft Coalition, which is a conglomeration of Smile Train, UpSmile, Global Smile Foundation, Canadian Transforming Faces, the American Cleft Palate Association, and the European Cleft Organization. And we set certain guidelines, which is the minimum core, and what do you need to achieve for in developing this kind of comprehensive cleft care. So it's really incumbent on all of us to touch on the importance for enhancing quality of care, training, and empowering people on the ground as well, and providing them the tools and the means, because we can't keep running from one country to the other, trying to operate on patients and then running out and without all the proper follow-up that needs to be done.
Excellent. And I think that maybe the World Coalition in Cleft Care maybe has some thinking around the digital issues in different countries, because it needs to be taken up at sort of policy level, doesn't it, at government level, all of these very difficult technical problems. I mean, that's way beyond this particular seminar, but or roundtable, but that's actually what needs to happen. And hopefully COVID-19 will have really made that a very appropriate sort of, need for all of our countries, actually. So let's carry on. We need to think, let me just go back to anything else anybody wants to say. Well, I'm just trying to read as well. We all need to think.
Debbie,
yeah.
Is Matt Fell here? I wonder if I could just expand on that question that I put in pre.
Please do.
I think I was just thinking that with the explosion of educational resources in COVID has been amazing, but with all of that power that there could, of international education, there could potentially be downsides potentially if local providers felt undermined maybe by what was said on the education. So as an example, I just wondered, presumably everyone thinks that all the educational opportunities are incredible, but has anyone found the educational opportunities negative at all, or have they just all been positive?
I think that's what I was trying to translate your much better way of expressing the question earlier. So I would like to try and dig into this idea as to how appropriate all of the sort of education webinars are, and whether there is a need to be more specific to local needs. Or more.
I think so, Debbie. I think there's this huge opportunity that is there for us to create, if you say, culturally specific or situation-specific kind of training. What's really happened is we are now accepting that we can do online training, but we were not so accepting of it, I think, even a couple of years ago. But now that we know it's possible, it's not just a one-day, two-day program, but something that goes sustained.
Yes.
Over weeks or months, so you can really see that it's.
Rupert, do you want to go on audio only just for a moment? Yeah.
To the max. I think that we need to rethink it. Did you lose my audio?
I can hear you now better. Yep, that's perfect. Thank you.
Can you hear me?
Yes, we can hear you. We can hear you.
I'm saying we need to rethink the way. Yeah, we need to rethink the way we will provide, this training, and I think that.
What we have done, Debbie, actually, to address this issue with the comprehensive cleft care workshop, we are looping back into the same continental region every 3 years. So every year it's being done in one location, and it comes back into the same location every 3 years. specifically to address the needs of the people in that region, because the demands in Latin America might be different from the demands in Southeast Asia and the Indian subcontinent, so on and so forth, and the same thing for Africa. So, at least our workshop right now is set all the way into 2025. And looping back into the same continent every 3 years, and in hope as well of addressing the specific situation that the questionnaire actually has asked. And we've done also a study whereby we surveyed our attendees, and certainly it seems to have impacted the quality of their own care delivery following the attendance of such workshops. But one workshop alone usually is not enough. You need to keep reinforcing it over and over again. And I think what Transforming Faces has done as well is amazing and commendable to try to be able to keep reaching out to people. And I think the COVID-19 has allowed us to kind of think out of the box and reaching out to each other in this virtual medium. You're on mute, Debbie.
Yeah. Thank you very much. Puneet, I'm sorry I missed seeing you. You want to say something?
Yeah, I have two comments, Debbie. Actually, the first one is about, this COVID time has led to a lot of research. You find a lot of articles on the net. Every week, things are changing. This is called a butterfly effect. What happens is that at the time of COVID or any crisis, people are publishing quickly. But there also, these articles are reverting back. Like the HCQ thing, it went through that it's very good for the professionals to have it, and then they concluded that the research is retracted back. So there's a word of caution to what is being published or shown as research in this time quickly. Should not be, we don't have to jump the boat. That is the first comment. Second comment is that, this additional technology, which is coming up and bringing a lot of training, is also causing a lot of confusion. Because there are different modes of modalities. It's very easy to interlink with internet, and there are a lot of courses and a lot of things happening. So it brings about the need, what Dr. Osama was saying, that quality and coming together on a platform, like you said, a coalition. We come together and we are able to deliver something with quality instead of confusing the participants, because some people might have access to some parts of the globe where they are giving in information which might be partially correct. So these two things I wanted to comment.
Thank you.
Hello, good morning. I would like to maybe intervene and give you my experience.
Yes. Can you say your name? Is it Diane?
Yes, I'm Diane Erquiaga, and I'm the program director for Smile Train in South America. And this challenging times for all of us, and I'm in Peru, so imagine, there's a lot of things happening, unfortunately, in Peru. These challenging times have helped us also to take initiative and give us the opportunity to new possibilities. Smile Train, I'm the program director for Smile Train in South America, and we have several medical councils that respond to our global medical board. So I work directly with the South America Medical Advisory Council, and through them, these are 13 specialists and different 13 professionals we have plastic surgeons, craniofacial, speech pathologists, psychologists, orthodontists, pediatric dentists, 13 well-known professionals in the region. I oversee all the Spanish-speaking countries in South America. So through the SAMAC, we did kind of like a pool and decided several of the important issues to train. So we've had webinars with 300 people attending, and they had all in Spanish, and they have varied from different subjects. For example, cleft surgery during COVID times, or secondary surgeries, or different topics, pre-surgical orthopedic techniques, results, and scientific evidence. With right now, currently, a Smile Train through our team in GANS, we have developed a very high-level course for speech pathologists, and the latest we got is the accreditation from the speech department from the University of Chile. So this is a course, it's a 130 hours course that in 2 days it got filled. I can only take 24 participants for semesters. So this is a third version, and believe me, I already have a long list of participants that want to attend. I hope to be able to continue providing this course, and it's such a success in which we are creating also a network among all our speech pathologists, the Spanish speaking in the region. So I think this will open the door for lots of great opportunities.
Okay, thank you very much, Dan. Can I just clarify, is that 130 hours of Cleft teaching in speech pathology, or is it general?
No, it's just Cleft, and it's 12 sessions, divided in 12 sessions, and then there's a follow-up of about 3 months in which the trainees rotate among the groups of the trainers, because each trainer has a different specialty. So believe me, I'm very proud about this course. You know, they work
It
very
sounds
well.
really interesting.
Very
Yeah.
nice.
Excellent. I'm sure we would like to hear more about it, and certainly something this event has thrown up that we can explore. So anybody else wanted to put anything forward? Puneet, can I come back to something you said? Is Puneet still with us?
Yeah.
I hope he is. Oh, good. Puneet, can you just explain when you said about the research that's coming out at the moment, and that actually it's coming out very quickly, and we have to be wary of it. Can you just expand exactly what you mean on that?
See, I'll take it as an example, because, you know, I elicited the butterfly effect. What it means is that, you know, as soon as the butterfly is matured from a pupa stage, it's not grown, and we don't know much about things. Like HCQ was initially, when the pandemic started, everybody said that, you know, hydroxychloroquine, if a clinician takes for some weeks, is going to work very well. And then they retracted it, finding that the research was not, you know, was not up to the mark. So what's happening is that in this time, everybody is publishing because people are freer, lesser patients, things are together, you know, everything's happening very quickly. So we have to be wary, because it's called, like, I was with you in Great Ormond Street, you used to call it the bandwagon. You know, everybody is wanting to just jump on and get something through. So one has to be very wary and careful about it.
Okay, thank you. Thank you. Let's see. I would like to take us, let's see, can we talk a little bit, we haven't talked about this yet, but how and it's so important, and I know it's a subject, it sort of overlaps with another roundtable, but Sarah Hodges was very powerful in what she said, and how we support each other at the moment, knowing that actually our own personal situations and lives are fairly difficult. They're changed for us all. And so how are teams managing to support each other's? How are professional groups managing to support each other's? Are there experiences that people would like to share with the group that work well, or perhaps things that haven't worked so well?
I think it's an evolving process right now. There's certainly a lot of challenges. As Puneet had mentioned, there are a lot of treatments out there that are quite questionable. The public is completely lost at what the reasonable things are and are not. And I don't, at least from my following up on the news, I don't think we're going to have the vaccine, the double dose working, and the world, the global community basically immunized before the end of next year. So this kind of thinking that within a few weeks we're going to be able to vaccinate 7.5 billion people, is a tough thing. And the statistics, at least that I've heard yesterday, at least in the US, of 330 million, if you're expecting a herd community, herd immunity, thing, you're talking about some astronomical number of death in the process as well. So we have to adjust our life. That we are not going to be able to probably resume reasonable life before end of 2021, and we have to be innovative in that regard of how do we deliver care in a reasonable and safe way. In our case, I mean, we canceled 4 missions because of the COVID-19, which has impacted the lives of a lot of patients in the process. So we are going to go ahead with our Beirut mission end of November with all the precautions that many of our colleagues have mentioned here and more as well, but at least to try to provide some reasonable care for some of the patients. Certainly not ideal as we used to do before, but life cannot stop completely, and it's a kind of work in progress. And I think, you know, what Transforming Faces has done and Smile Train and others, we need to continue to elaborate on these things to figure out solutions that will help us in the coming 12 to 14 months of delivering reasonable care. So.
Maybe I can add, Eddie, David, if you allow me,
please do.
that in terms of support and training, I want to say that our local partnership and leadership are the best model for training. For example, we have a very tight community. WhatsApp in South America is what works the best, or in Latin America. So we have provider, in terms of supporting our patients, we provided so far, I don't have the stats for August, but from April to July, over 11,000 telehealth consultations in the region between speech pathologists, nutritionists, nurses, doctors, dentists as well, orthodontists. You know, it's amazing the quick response our partners gave us when Smile Train offers support. And the fact that we have strong partners and local strong partners, we continue to deliver care. And now some of our partners are starting to provide surgeries. So we're supporting them with PPEs and with for them the expense for the COVID testing as well, to make sure that all the precautions and safety measures are taken. So our local leadership and partnership is just great.
Thank you very much. And I think that some of that learning and there will be continuation of using this technology to reach our patients without a doubt beyond COVID, if that ever happens, as Usama has just alluded to. But there's a very interesting, somewhat controversial question from Hugh, which says, does pushing our models beyond adapting to COVID actually mean that we should be building a new brand or a brand new model to respond to COVID for many years? And for example, no missions. So let's open this one up.
No, definitely. That's the only solution, to develop local capacities, you know, and to continue follow-up care from birth to the child is completely rehabilitated. We need local teams to continue to do that great work.
Okay, so I think we've got some wonderful music somewhere. Just if you can mute, I think it could be, I'm not sure. That's fine. It was very nice. Thank you, Diane. So you're in pro that we work towards no missions in the future, and that actually we're trying to build some sort of new model of using all of the resources that we have.
We have a lot of resources. I work with Smile Train, so we have a lot of resources in that sense, in local partners.
Usama, can I ask you to respond as well? I think you're on mute.
Yeah, I just answered actually, Hugh. But again, the key point is, one, we need to follow exactly our model in the article that I just sent you from the CPCJ. And in line actually with what Diane is saying, we need to invest in sustainability models.
Yes.
We need to empower people on the ground, but also keeping in mind that we need to keep raising the bar, as we have done and many of our sister organizations continue to do, to make sure that we're delivering the safest care possible for our patients. You know, as you know, COVID is not disappearing. So we really have to think in the coming 2 years, how do we modify our work? We cannot just sit at home and just keep doing webinars all the time. Things are probably deliverable, but in a much safer manner, and certainly more costly manner for all of us, with the PPEs and the travel restrictions and the precautions and the sequestrations and all these things. So it's going to be a logistical nightmare for many of the organizations who are planning to resume some of the daily activity. But on the long run, the diagonal model that we have believed in all through, which is empowering people on the ground, I think is important, but also giving them the tools to be able to do this. We just spoke with our local partners in Ecuador yesterday, and they're going to start resuming surgery, cleft surgery, at Leon Becerra Hospital as an Ecuadorian team, a Global Smile Foundation Ecuador. And we discussed all the guidelines, precautions, this, that, anesthesia, pre-op, post-op, pediatrics, and so they're exactly as we are basically there, but they're doing it on their own with our just remote support and guidance whenever they need to. And this is, I think, the question eventually, the answer is on the long run, whether it's sustainability development.
Yes, I think that's a very, very important message to end that discussion on. There was one question that Hugh put up earlier about research. Here we go. For the group, how closely are people following research in your teams? Is it everyone, a few people, or just the team leader? Can we open that up? Has anybody got anything they'd like to respond to?
Can you clarify the question, please, Debbie?
Hugh, would you like to clarify your question?
Sure. Yeah, certainly. I just realizing that many partners, obviously life is very difficult during COVID. Keeping up on top of research can be difficult. One of the solutions that different NGOs have been trying to do is provide access to links of good research, things people are actually using. But I think my question is to everyone saying, just right now, who is following research? I think Dr. Puneet's point was really well taken. And how many of us are actually on top of these things? Is it usually just one person who's bringing it to the rest of the team? How does research trickle down into low and middle country contexts in terms of what's being published or pre-published, whatever?
We have utilized actually this downtime for us to be much more involved in research and publication. And we currently have 45 papers either published or actually in the works in the last 12 months alone. And this also initiated the 800 book reference textbook that we're working on as well in comprehensive cleft care, interdisciplinary cleft care. So the fact that we have our own electronic medical record is also helping us do a lot of our assessment and retrospective work and things like that. But I certainly encourage everybody to try to utilize this downtime as well in looking at their own data analysis and try to share their own expertise as well in the field.
May I comment?
Yes, by all means, Felicity.
I think it's such an important point that's been raised. The pace of change of knowledge at the moment with COVID is so rapid that even full-time researchers are struggling to stay abreast of the science and also to evaluate whether what is published is peer-reviewed. There's a huge amount of data that's coming out on preprint servers that has not been peer-reviewed, but the media gets hold of it and that is then pushed out. What my colleagues who are in full-time research have been doing is bringing together groups to do rapid reviews. And I think one of the really good examples of good practice is also being very open internationally about what you are reviewing. The last thing we want when we are pressured for time, processing more rapidly accumulating information than in any normal situation, is for people to say, right, I'm working on PPE, I'm working on aerosol exposure during intubation, and then put the right people together so we minimize duplication of effort. And then I think there's the other bit about translating sensible, brief findings to clinicians at the front line. And I don't think that's been done very well, certainly in many countries that I've come across. And that's what opens up the vacuum for misinformation. And that then makes people lose confidence in the science. Whereas I think it's distilling the key messages and communicating uncertainty where uncertainty exists that's so important. And I think we could and should be doing better at that.
Thank you very much, Felicity. And I think adding just a comment to that is the need for when we are doing new things, how we have to evaluate them and how that implementation into clinical practice should be, we can use the quality improvement methodologies to look at that as well. So we've got some way of being a bit objective. And I think we're beyond the time where we just say, oh, it works. And we need to be thinking about evaluation too. I just would like to end with something here. I say end, I think I'm getting to the end. Matt Fell, you've raised a very interesting point. Could you just talk to your point you've just put in at 3:01 p.m. about investment in sustainability models?
Not sure I know what I'm talking about, Debbie. But, I was on a call yesterday with people from the global health surgery department in Harvard, and they were just talking about the fact that most of these interventions are at a government level. And I just wonder at this time when they're all strapped for cash because COVID interventions are so expensive, what evidence or research or what are we going to use to persuade local governments that it's Cleft that needs to be invested in?
I can jump in and speak to that a little, if that's okay.
Yes, please do. Sarah, where are you? Let me look. Oh,
Here.
yes, I can see you.
So I think there are two parts for that. And first, it's kind of preparing the stage by investing in these partnership models over the more mission-based. Smile Train is entirely local partnership-based, and that has really allowed us to form these advocacy relationships within countries. And once you have those local relationships and that partnership model in place, I think it's important to approach advocacy from several different angles. It's important to know the structure of the country you're working in and who you would go to within the government, including the Ministry of Health and the Ministry of Finance, to make the case and sort of know who you're talking to. And to prepare for that, it's also important to have that evidence-based research to back it up. So you can call meetings and say, hi, we're this organization, we have these partnerships in your country, and this is why, this is what we're supporting, and this is why it's important for your population and can contribute to your national development. And then in addition to that, I think these coalitions like the Harvard PGSSC group that you mentioned are so important right now. Global surgery has just become such a large advocacy platform right now, and ensuring that Cleft is a part of that is something that Smile Train and other Cleft-related organizations have really been doing a lot of work on. So I think joining in with the G4 Alliance, with the Harvard PGSSC, with the Frontline Health Workers Coalitions, to be aware of the advocacy windows where we can have influence at the international, national, and regional level is very important.
Thank you, Sarah. That was very helpful and insightful. And this whole thing of how we're going to influence really the powers that be in all the countries, and then for countries to speak together, because whatever gets developed has to be across borders. So it's a hugely complex, the digital scenarios are hugely complex. But
I think that was all. I absolutely agree with all that. And I think something that maybe we as an international group of Cleft clinicians can do is to agree the minimum acceptable standards of care internationally that are non-negotiable. One of the things that helps in our UK prioritizing exercise is that we have agreed timelines for when things should happen. And having national and international guidelines with the force of the international Cleft community behind them would be a very powerful evidence-based lobbying tool because it is going to be, I think, at some point, whoever shouts the loudest will probably get more resources thrown at them, and Clefts is small compared to many other specialties, so we need to think how we can strengthen our voices strategically.
That's very good points, Felicity. Okay, I'm just looking to see if there are any other particular, Inoka has asked for any platform which shares research for those that don't easily have access to journals and databases in lower middle income countries. Are we aware of any of those resources?
I think it will be nice if we can talk to the CPCJ and the ACPA to see if, I know they've been struggling and getting more members on board, but now in this virtual COVID-19 pandemic situation, if maybe they can lower the membership fee or do an online membership fee that will give access to the CCPCJ journal. I know PRS is pretty expensive endeavor, but short of this, I think between the CPCJ and maybe the International Craniofacial Journal, if we can utilize our connections to see if they will consider that. I'll be more than happy to talk to CPCJ myself and raise this thing with them. If anybody has any connections with others, and even if they do it on temporary basis for the coming year or two, that hopefully will give access to the online versions for many of our colleagues in lower and middle income countries.
Just on time, sorry to interrupt. I said we would give a 5-minute warning. I was mistaken. We are actually at the end time. So I think that's a perfect note to end on.
I have to say, well, that's fantastic because I don't have to try and sum this up, which would have been very challenging. But what I'd like to just end on is, oh, have we ended? Okay.
No,
have I been ended?
I'm just sharing the black screen so people know where to go.
I really want to thank everybody because you've all been a fantastic group. To our panelists for their lovely contributions and setting the scene and helping us provoke us into thinking of things. And against a background of life that's pretty tough for some of us now at the moment during this pandemic. And you've really kept me on my toes. So I've really enjoyed speaking to you, and hopefully we will pull together the conversation and make some useful comments for you to have. Thank you very much indeed. Enjoy your rest of your day.